for the sake of time today, do you guys want to get started with the meeting? All right, so we'll call it to order. Did everyone have a chance to look at the minutes from last meeting?
I move that we approve those minutes.
I'll second that. All right, is everyone in favor?
Aye.
Anyone opposed? Okay, motion carries. We can move on. Mike, any correspondence from last meeting?
Sir.
No? Sounds good. Brendan, I heard you giving some of the updates about the cadaver lab. Any other updates for the paramedic program and EMS education in the area? You and Bruce?
My paramedic program is still sitting at 18, a little more than halfway through. Yep. Went to cadaver lab on Friday. Always a good time. No one vomited, which is always a positive. As far as our EMS classes, we were offering two original and refresher EMT classes this coming fall, starting August 29th, I believe. I've gone to a couple of fire advisory boards meetings, and I go to another one tonight to just kind of let our region, our regional departments know that this year, every student will be paying right up front. We're moving away from the state reimbursement model and just charging, whether they're with a department or not, everyone is charged the same amount right up front. So, so far, it hasn't been met with a whole lot of crazy questions or anything. Departments just ask questions, but I think they fully understand why we're going to that model of pay up front versus reimbursing on the back end. But yeah, that's about it from my perspective.
Anything else from how many EMT classes do we have going on?
Presently, there's none going on right now, at least in Chemung and Steuben. Schuyler finished up one. We finished up two in February, and Schuyler just finished up one in March. And like I said, we're slated to hold one here in Elmira in the fall, and Corning as well. And I believe Schuyler County is going to hold one probably in Monterey or the greater Watkins area, somewhere up there.
Excellent. Yeah, I've been hearing anecdotally more and more from a lot of our EMTs and paramedics that we're facing more and more shortages. And the more people we can get out there, just better for the community. Anything on QI for the region? Nope. Didn't think so. Just figured I'd ask.
That's a question for the council.
Yep. Rick, anything to add for that?
No, nothing to add.
Sounds good, man. Dr. Hallinan sent out a nice revision of one of our STREMAC policies for the CME. If you haven't had a chance to look at it, there were just some wording and some dated portions that looked like they were removed for it. But if you guys all have a chance to take a look at it, we can talk about it either now or next meeting. Has anyone actually taken a look yet?
There really weren't a lot of changes. I mean, other than taking out videotape and,
Yeah.
push a couple things around, but.
Yeah, I think certain mentions of things like videotapes and Laserdisc are kind of a little bit dated for us. So updating to the modern era is probably good.
Most of our CME things, our questions say like, is there a conflict of interest? I didn't add that in. I didn't know if that's such a big deal for these.
Yeah, I think in general, when you're doing the CME stuff, disclosures, conflict of interest is all kind of should be standard. So we could put some brief little thing in there for it. But thanks for getting that out. That was helpful. And just trying to bring everything up to the modern era, just so that some of the policies that haven't been reviewed in 10, 15 years are just getting a fresh coat of paint on them.
I have two small edits, and actually, they're not. The state recently put out a CME recertification administrative manual, and they have a CME verification form. We had one. I'm just suggesting that we use what the state put out.
Okay.
And same thing on the, state one they put out.
Another one for Rick, if there's anything that the EMTs or paramedics in the area, you're looking for specific CME, you're looking for specific topics that you feel like anyone from this council could give a lecture or a benefit just to improve EMS, always feel free to let us know and we can try to get someone interested in the project.
Absolutely.
Can I,
All right.
or, so we can give like, you know, talks on, I actually like brought recently, now this is a little, so like in post police department, I brought like information to the police department on like addiction services in the area, and they knew nothing about any, so he was very happy to get like information that they could get people when they pick them up. And
Sure.
I was wondering, like, you know, I mean, I would be, certainly we could do something for any of the agencies to, because the addiction stuff in Corning and Dana Post is getting like a little crazy. I can't even imagine what it's on Myra. But just so these agencies have like stuff in hand to give to these people, you know, and then like an education event on like, you pick these people up over and over and over again, you know, what can you give them so that when they do hit rock bottom, eventually they can go like, oh, here's a piece of paper with a phone number on it or whatever.
If fire departments or police departments are interested, the same program that Arnett has partnered with, the New York Matters, they're getting a lot of funding for especially opioids, not so much for a lot of other things, but especially opioids, where we have an iPad and they can actually go on the iPad. They can give themselves an appointment at one of the substance use disorder clinics, and they can actually make themselves an appointment as early as the next day. And
I sent an email to our administrators and they never even.
Yeah. I can give you the contact. There is a gentleman in our region, Kurt Kleefield. He is handling kind of the resources in our area. He's actually partnered a little bit with Arnett in order to send people for lab draws, and a little bit with Casa Trinity just so that they can arrange needle exchanges. They can do other services like that for our community. So he's actually a great person to reach out for a lot of the stuff you're talking about, because they have resources available that might be being underutilized that I think our even EMS, police, fire departments could probably utilize and probably save them a lot of repeat visits.
Okay.
On top of that, they can also help pay for Narcan for these patients so that a bad day doesn't turn worse, and help arrange transportation even for appointments. But after the meeting, I'll send out everyone that contact information just in case your hospital is interested or an agency you might be affiliated is interested, because especially in New York, it's hard to refer these people without the proper channels in place. And this kind of takes it out of the equation just by giving somebody an iPad and they can make their own appointments.
So, Doctor, on the one thing we're challenging on the education side is, and we're trying to get in front of that, is there's a lot of agencies out there handing out Narcan with minimal education. This is how you do it. That's it. And just keep giving it to them until they get up and run away, which is problematic for the hospitals because there's no offering for intervention. So the education piece that we're trying to deliver is that we're trying to get them breathing, not to get them awake and not to get them running, stuff like that. So they have the opportunity, unfortunately, to get to the hospital and let fine folks like you try to intervene and get them the right source. But like I said, the challenge is the others out there that are distributing Narcan. You know, the education piece with it just is not strong. It's here's how to do it. Rip open the pack and squash this thing.
When I became a paramedic and heroin was still heroin, not fentanyl, it used to be you give just enough to keep them breathing and then you transport them to the hospital. Then fentanyl came in, and it's not uncommon to see someone get 8 to 10 milligrams before even arriving. And just like rapid fire, 4 to 5 injectors used.
Yeah.
So I agree, education's probably of paramount importance right now, because they're not even waiting for the medication to take effect. They're just continuing to give and give and give.
Correct. And and that's what we're trying to overcome, but, you know, obviously, we have no influence with those other agencies who are distributing Narcan. But I hope that agencies, you know, police, fire, rescue are not going through those. It's an easier pathway for them to get Narcan, but it's not the correct pathway. So.
With your community resources, Mike, if you want to reach out to them, I would be more than happy at any point, if any of them have any questions, to discuss it with them about administration, all that other stuff. Because I feel like overusing Narcan and waking somebody up who's not ready to be woken up can have a detrimental outcome, because they can go out and use again. They stopped breathing for a reason. The Narcan has a short half-life compared to the substance they used. So therefore, you're setting them up for failure, not for success.
And that's exactly what we've been preaching out there, and you know, we're getting in front of police cadets and, you know, the fire and EMS agencies, but, you know, some of the EMS agencies have gotten it from these other places, and it's a 15-minute education thing. It's basically how to do it. So that's problematic. And just
I'm good.
I'm with Rob. I'm delighted to go do education anywhere that it would be beneficial.
great.
Yeah, especially those that have an affiliation with a residency program. We would always love to do an education program that we can put on our CV so that the ACGME is satisfied.
So just as a sidebar, EFD set a new record with 3 in one house.
Same house.
Oh, yeah, I remember that one. Yeah.
This is the second time. They've done it twice now.
Yeah, but this one was better.
Oh, there was nothing good about that one.
Oh,
No, there was nothing.
more involved, I should, is
Yeah.
not the word, is the correct word.
We had the same house.
And then about 20 minutes later, one on a different scene. So
It's just rewarding when you get these people in for Suboxone, and, you know, I mean, I know that it's kind of like 60-40, you know, you get people who are using it and selling it on the street and all that, and I understand that, but like, you almost have to kind of mother these people through. And the first step is like getting them in so that they're actually in medically assisted therapy, and then trying to hook them up. Like, all of these things have to then occur after that. If people don't even know about medically assisted therapy, then, I mean, I know they know about it, but they're not getting plugged into it. But I mean, we have a lot of people who have been gotten jobs back, kids back.
Yeah.
Over like the faith-based groups that we know about do very well. There's some in Riverside and Corning that, and Canyon Post, that are amazing. I don't think a lot of people know about them. Like Two Rivers Church in Riverside, they have like groups, they take them out kayaking on the river. It's not like sit and talk about your drug use, like take them out, you know?
I think our biggest issue right now, though, and anyone working in the emergency room is for sure of this, is methamphetamine use is skyrocketing, and the acute psychosis related to methamphetamine use is creating a huge drain on resources. And that is a huge issue for all of us right now. Right now, the NY Matters program, they'll also get them into treatment, but the downside is with methamphetamine use, there's nothing to control their cravings. Their brain gets so altered from the release of serotonin and dopamine, especially dopamine, that it's all they want to do at that point. So as much as I love the state rallying behind opioids, which they're really doing right now with NY Matters, with other programs, I think we're kind of chipping a little bit off the tip of the iceberg in our mental health and our drug-related services at this point. But we can talk about, if anyone ever wants to talk about substance use disorders, I am free offline to talk about them. It is one of the things as Kathleen was mentioning, I'm speaking with LECOM in a few weeks just on substance use disorders and the treatment in the area. But we can move on just for the sake of keeping the meeting on point. And Mike, how's EPCR compliance? Any issues?
For all intents and purposes, we have everybody on board that's gonna get on board. There are 1 or 2, and we've shifted that burden over to the state of New York.
Okay.
And let Mr. Brody come down and do his thing.
All right. Any more updates on ED or EMS delay times? I haven't heard much from anybody saying that it's long waits in our region. When they leave the region, we hear a lot of it.
as far as diversions, they're way down and they're primarily in Onondaga County, upstate, and all their kinfolk up there. Those are the only ones we're seeing of late. There's a one-off every now and again. Binghamton's been up and down a couple of times, but nothing
Yeah.
significant.
And volume is certainly turning up in the region. I know Dylan and I see that at Arnett. I'm sure Chris and Beth, you guys see it at your facilities, where the lull we hit with COVID is we're back to pre-COVID numbers, if not more some days. All right. Again, we'll always talk if there's any research or anything that someone wants to bring to the meeting, any kind of projects going on in the region, that's fantastic. I know, Kathleen, this is something you might be interested in, is through Eastside Family Medicine for our patients with methamphetamine use disorder and issues like that. A lot of them reported that food was their primary reason. They had no access to food, so they used meth so they wouldn't be hungry. So Eastside Family Medicine set up a food bank. So if there's anybody who is struggling with substances and needs to be referred somewhere, feel free. Eastside is willing to take on these patients in Elmira. That was an email I got about 6 hours ago, so I figured I would just mention it to people here. And new business. I see Brian's on. Brian, you have anything for us? Oh, yeah.
Got to undouble mute. No, I don't have anything to report. It's been busy, and nothing really new to report, at least from the state level. We met with Mike yesterday, myself and Ed, and are moving forward with stuff. Hopefully we're going to be out at your meetings live, and out doing inspections and kind of getting back to the day-to-day work of the Bureau. So look forward to that.
The biggest thing I liked at the last meeting was, since the lack of availability of ALS in certain parts, is the Igel Project, and that was a huge step.
Yeah, I was very happy with the way they set it up so that it didn't have to wait until the next meeting. So.
All right, thanks, Brian. That'll bring us into the Igel Project. There's a pilot program going on in the state of New York, which agencies can now apply to be part of the pilot program about the use of Igels in the field, not just by ALS, but also BLS, for timely CPR, for more effective CPR. If you don't have access to advanced life support to intubate or put in an advanced airway, you'd be able to train staff to do Igels and potentially get more effective CPR with, I guess, less chance of over stomach distension and creating a mess in the airway for the next provider. If there are agencies that are interested, Mike and I have the information. There is a form that you could fill out to apply to participate in the program. And I've spoken briefly with Airways for it, but if the other agencies are interested, we can pass the information to them as well.
Rob, it's cardiac arrest only?
Brian, you want to shine in on that? I actually got called away from that meeting because that was the day I tested positive for COVID and got pulled out of it. So I had to leave during it.
I believe so.
Yeah. The form I have here says in cardiac arrest. I don't
Yeah,
see anything
so-
else on there supporting the use for respiratory failure or anything else.
It's a pretty big buy-in for BLS agencies that are hurting for cash to have a $1,500 entitled CO2.
Yeah, that's gonna be potential.
Yeah. I think it's great, but then you also have to provide that education to them. But it'd be nice to have. I wanted to get one for my go bag, and I have been price limited at the moment because of that, right? Like you can get I think it's Medtronics or someone makes one that's right in line, comes with a waveform, gets you all the things you need, but the buy-in is quite high.
Yeah, there certainly seems like it's a step in the right direction with some things that still need to be worked out and figured out for it. But for agencies that ALS intercepts are quite a ways out, it'll buy them some time or buy the patient some time and potentially a better outcome because you can oxygenate maybe a little bit more effectively. That was the biggest update from CMAC this time. But you got something, Mike?
I believe the comment period for that closes this week, doesn't it, Brian, for the IVL thing? And they're gonna move quickly to codify that and make it part of the BLS protocol?
I believe it was 30 days comment period. And so if you say that the end of 30 days is this week, I'll believe you, but I don't remember the exact date that we had that.
I know Dr. Daly set a target of the first week of May, so I'm just regurgitating what Daly asked for. But it is a really good product that Dr. Murphy and her group put together, and it's good.
Yeah.
So I think they're gonna move quickly, and they just scheduled a meeting for the end of June, for the second or third week of July, one or the other, they're polling for that. So I would guess that they will wrap this up rather quickly.
I haven't heard from anyone saying that their agency was close to adopting it, so I'm not sure how quickly it will come to us. But if the agencies are interested and if someone wants to bring it to their agencies and see if they are interested, the form is out there, and if you need it, just talk to either me or Mike and we'll get you a copy of it.
So if anyone's involved with ACES, just to reiterate that it has to be approved by CMAC, then by STEMSCO, then by STREMAC and you folks, and then by their medical director, then they can use it. So
It's a process, but
have to buy in. So just because it's a state adopted protocol, doesn't mean they can run out and do it.
no, I don't know. But if the agencies are interested, I don't know if I want to start pushing it through our meetings and making it a contentious point of debate at this point, unless the agencies in the region are willing to do it.
Right.
Again, if there's no point in making a STREMAC policy or a STREMAC protocol, whatever we're going to do for it, if our agencies aren't going to buy into it and aren't going to participate.
You can just adopt and agree
Yeah.
to without getting too complicated. But just, I know we've encountered some BLS providers who think they're ready to go and they're not, because it's
Oh yeah.
not an adopted thing. So
I think any agency that does it would have to contact somebody who is experienced with their use to set up an education program. I wouldn't imagine that the medical directors would sign off on it without there being appropriate education in place for it.
I believe Daly is putting something together. But that's to be supported by a local, obviously a local CAC. I think they're putting together a video, and that should come out about the same time. That's the education part of the education piece. And I may have the names and times wrong, but I thought it was Daly. Maybe Brian knows better.
I would agree. My understanding was that there was going to be a kind of system-wide generic training that everyone would go through that was in the program that group was putting together. And I think that was part of the original holdup, was to what was involved in that training. That's why it had to come back to that last meeting.
Yep. It's a good thing. They wanted to put the whole thing together and make sure all the ducks were in line in the education.
Oh yeah.
Good process. Hats off to Dr. Murphy and Daly and whoever else participated in that.
Yeah. As hard as it is to get in certain things through those meetings, for someone to take that big of an undertaking, it was excellent to see the ambition and the follow through. And it seemed like it went through pretty quickly compared to other things. So it was obviously a topic in need. It was obviously something that New York in general, outside of certain counties, were struggling with EMS. So it at least provides better care for our patient population. All Alrighty, and I think, Mike, the only thing left on the agenda that I've got is the agency updates in the PAD.
So PAD, AED renewals, Addison Central School District, Arnett Mall, Corning Painful Schools, City of Lamar, DPW, Amstar. We did ours. First Heritage, Hammondsport Central Schools, Jasper Central Schools, the Chase Construction, Navient, New York State Academy of Fire Science, Scarlett County SO, Wayland Cohocton School District. Under ambulance renewals, we have Avoca renewed, Troopsburg renewed. Under BLSFR renewals, we have Baldwin, Horses Fire Department, Pine City, Webb Mills, Wellsburg, Mecklenburg, Montour, Watkins Glen, Campbell, City of Corning, Coopers, and Hornby. They're all in line for the renewal. There were a bunch of folks who had expired, and we're just trying to get them back in the fold.
The only one that seems suspect is that M-Star one. I don't know.
Catch up, just making sure he needs some. They're good.
Dr. Lincoln Heil has an item for discussion. We can turn the floor over for her for a minute.
Hey, thanks. So one thing that I did ask Mike to add to the agenda was reviewing the online medical control physician credentialing
Sure.
policy that we have. And it might be my bias just because I get to onboard all of our new people that are coming in. But I feel like we might be able to streamline this just a little bit to take some of the workload off of the region and each hospital site, as well as potentially STREMAC, just because I'm not getting the information back as to confirmation that someone's been approved from the final base station. So I'm not sure if there's hesitation with making modifications with this. I know that one of the other consuls really doesn't have a policy because they have so many locums coming through the area that they wouldn't be able to keep up with it. And then no one would be answering the phones. So I'm wondering if we can simplify things to just have a letter from the department director saying that the physician upholds a New York State license. They meet the specialty or ACLS, BLS training as necessary in order to work in their department, have been educated on where the protocol for New York State is in the department. So they have those resources and kind of submit a letter rather than having a test that's sort of, for a question test and going through all of that. But 5 questions.
One's extra credit.
With there now being collaborative protocols where the majority of the state follows them, I wouldn't imagine there's a huge variation between somebody who works in Binghamton coming to our region versus going to anywhere except for the regions that have their own protocols. Like New York City and Long Island are a completely different set, but that's different. I don't really have a problem with just adopting where the individual hospitals make sure everyone knows where the protocols are located. The physicians sign off something that they've read them or not even having to take the test. Does anyone have an objection to kind of streamlining it to make sure that at least the doctors are aware of where they are, they've at least looked at them, but not have to take a formal test?
Or submit, a diploma or a letter from my hospital president. I mean, I feel like if we can get them through the credentialing at each hospital that they work in, hopefully we can let our credentialing committees do that work for us.
Yeah, I think that it makes sense to put the onus back on the hospitals to say, yes, our physicians are appropriate to answer your radio calls, and we don't need to be sticking our fingers further into that. I think you're exactly right to advocate for that. It should be the assumption that when we call a hospital, they have the appropriate staff to answer our radio questions.
I mean, 7 years ago, when the region was so heavily locums that every hospital was being staffed by a good portion of come and go doctors, I think it was more appropriate then to make sure that every doctor had at least looked at it, but now I think we have a pretty well established, at least at the bigger hospitals, individual
I think that was
providers.
the big issue, Rob, is
Yeah.
that years ago that we had some serious issues with locums giving inappropriate orders or just not understanding the protocol, and that's why this all came about. Speaking from the hospitals that I regularly transport to, we don't see any locums, but I can't speak of hospitals outside of our area. But that's the only thing as a paramedic and as an agency operations person is to make sure that medical control continues to run smooth and that we're not concerned about getting orders that are either outside the scope of practice or we're given or not familiar with our protocol.
Thanks, Eric. Yeah, I had a feeling it was something like that because I don't think, at least our bigger hospitals are not locum driven anymore. I think we have a nice supply of staff that have been there for at least months, if not years, and have every intention of being there for a while.
Just trying to play devil's advocate, I guess, you know, looking at some of our smaller hospitals, I mean, do we need this in place in order to support, you know, that functionality? Are you getting them from, say, Ira or Hornell?
I don't know.
If any issues around, you know, and like Rob said, it's all about familiarity with the local EMS system and with the physicians. I mean, a lot of the physicians were residency trained here locally and then coming in, so they're very familiar with us. So we're not seeing the issues that we were seeing years ago. The issues, you know, of medical control not really understanding what the role of a paramedic is and what the scope of practice for what a paramedic is, or at least what the scope is in our state and our region. But I don't see that issue now. I would just hate to have to go backwards. So, and then have to redo this process all over again. Maybe we should take a little bit of time, and maybe we can come up with a process that works for everybody, works for both the hospital and works to ensure that the physicians are familiar with the scope of a paramedic and the process of our local area.
Well, I think Beth nailed it when she said some of the smaller hospitals, you know, that's where we get anecdotal information that the medical control, you know, may not be what they were expecting. So my suggestion would be that there's some sort of credentialing in process, whether it is just that letter or whatever the process is, that there is something in process and that we do capture that information and we do have a central repository for that. So, you know, Dr. Lincoln Howe sends us a note that says the following are credentialed and here's our letter of credentialing. So
Our letter of credentialing and, you know, meeting satisfactory, you know, minimum of orientation to EMS. I guess my concern is are you going to tell Ira that they can't take medical control because they don't have something like this complete? You know, I
think a process that would be both more sensitive and specific, if you will, would be to have a very streamlined credentialing process, but then a more robust QI process that if there is a medical control issue, that gets reported to this group or a ad hoc subcommittee of this group, and we investigate it and provide recommendations to the hospital that was involved.
Yes, I think the goal is ultimately to get those smaller hospitals on board, you know, pick up that book and be familiar with stuff with that book. I mean, the anecdotal information we get is some providers are bypassing the closest appropriate hospital for medical control to get to someone who they know they're going to get the right direction from. So we also want to try to avoid that situation. So, but I think you're heading down the right road. It needs to be slick, clean process, and develop something that identifies all the steps.
It doesn't sound like this robust process you're doing right now is eliminating any of your issues.
No, I don't think it is.
Right, so,
So would you support me taking on like a revision of this policy? Just to try and streamline it a little bit and make sure that there's at least some, catch, if we need to do QI on a certain facility or something like that. But also having some more onus on the hospital and their orientation process.
Yeah, I'm all for like any of our policies getting updated, like that fresh coat of paint to make it more relevant to our region at this time. If we can come up with a better plan, one that results in EMS getting what they need from each facility and each facility taking some ownership and making sure they're educating their providers, I think that's the best solution for everybody.
Great. All right, so I'll give that a stab and then float it by some of our, prominent physicians here and see what they have to say.
We can also involve like STREMS with it to make sure that STREMS, as the paramedics and the EMTs in the area, don't have concerns for it, because they'll be looking from a different perspective than we will, and they'll probably see problems that we won't.
Sure. First, I'll take a stab at it and then float
Works for me.
Float it by some of the gurus in this region.
I have one more question on that though. Is there a mechanism in which agencies can refer issues to this or to STREMAC? Is there an email or a hotline or something they can call, leave that information? Or
There's an email.
how does it occur? Okay.
STREMAC,
But is it a
STREMAC at stremscouncil.com.
Don't know. Or me, they come to me or Mike,
Well,
honestly,
I
nine times out of
realize
10.
I just didn't
Yeah.
know if there's a way that they
Sure.
wanted to,
That's a good point.
yeah.
We should probably have a
Anonymously.
dedicated, so if
Yeah.
I anonymously want to say, hey,
Mhm.
I don't think I got the best, I should really email.
Right.
I mean, we could set that up through our website and shove it off to the appropriate to you and Rob. And let you guys, I mean, typically we get a phone call.
Yeah, we get a lot of
And
phone
we
calls.
call, Rob or Dylan, or typically both. And let them know, and it's out of our hands.
Mhm.
But it might be a better idea to get us out of the middle of it.
Yeah. Let it go to the specific, like, at the hospital, we have 3 people that receive our PI emails. And that way, there's no issues with it. They know it's coming to us, we're gonna evaluate it. It's not going to any one specific person, but it is actually being, looked at. And especially, I think it's important now with the whole Vanderbilt case and that nurse.
Good.
People are not gonna wanna self-report and have their name attached to it on a lot of instances. So it's not a bad idea to have like a hotline and an email set up that people can do that type of thing. That way you're getting the information real time if they are having an issue with the medical command position, because I mean, reporting a position is a big deal. And I think people fear retaliation. They shouldn't, but it's a different level. So,
But to that end, this QI hotline, hot email should be for anything. If the provider, and it should go, because they go in the same direction to the regional medical director and the STREMAC chair. So maybe if the council buys in, we could set that up and just kind of direct that and get it out there, whether it's provider or medical control, whatever the case. Any QI
Yeah.
needs to go through this.
Yeah.
This
So
pathway.
I like the idea of as Amstar is redesigning its website, building in some
Quick
widgets
button.
that report,
yeah,
and then it's not email and it's not your phone number. So
That's
you're right,
great.
the anonymity is key.
yeah.
We're gonna charge the council.
Sorry to add that.
No, I heard that. No, let's go. That's exactly where we need to be.
Hi.
I think if you, go ahead, Dr. Sheriff.
Yeah, I'd like to just make a comment. I had done a fair amount of locums, and each region has a bit of different nuance. And what was required for documentation purposes to work there for credentialing is you were given a copy of the manual for EMS and would have to read it and take a test, and that was part of your credentialing process. And if the hospitals require that for their credentialing for locums, it makes it easy as long as they're responsible for making sure that the stuff was read and the test was taken. And then if we were to make a policy that the hospital were responsible for doing that, it would be their responsibility. The needs for locums varies from day to day and time to time and year to year. So you don't know 5 years from now whether you're going to have a pile of locums coming in or not, but to not have them responsible for really knowing the material could come back at us at some point in time because they didn't take the test or they weren't aware, or somebody died because they gave inappropriate instructions or what have you. So they still need to be familiar with our protocols, and it's part of the credentialing process. That's my comment for today.
So just so everybody's aware, you know, there's 3 sources for the ALS protocols, which I think is what comes into question most often. You know, there's that Muru app, there's the collaborative protocol app, and there's of course the hard copy of it, which we supplied to all hospitals quite a while ago. They probably need to be updated, but Muru and the collaborative are pretty up to date. Muru I know is, collaborative I think is waiting for a little bit of an update, but neither one is way off base.
So I think probably the next meeting, we could talk about it a little more. We'll get it onto the agenda just to make sure it's not falling by the wayside, that we're making some progress on it.
Yeah.
The problem ends up being is I have no idea who's medical director or who's in charge of Skylar. And I know to some degree I can get in touch with the gentleman who's the medical director for IRA. Corning, we've got the illustrious Dr. Lincoln Hall here with us. Dr. Bowen or myself will gladly field any calls for ARNET. But I think we still have some holes in people to contact at certain facilities, because I'm not even sure that the council here that we know who's in charge of certain facilities at this moment. But I definitely like an update to it, because what worked for us 10 years ago isn't necessarily what's going to work for us now, especially with removing a good portion of the locums. But I definitely agree with Dr. Sheriff that there has to be something that they have at least addressed, that they've gotten a copy or they've been able to see the protocols and they know where the protocols are so that they can give appropriate medical direction. But I've got nothing else for this particular meeting unless somebody else has a topic.
Sure.
Rob,
Good.
Dr. Kellogg and I on June 28th, this group is invited to attend. We're doing a poster presentation for our paramedics. They're kind of doing their own version of some kind of meta-analyses, and we're kind of guiding them in the right direction. We'll be putting together a formal poster presentation June 28th at 10 a.m., like 10 to noon at Petrie West at the Arc. If you're free and in the area, stop down. I want to, I've kind of promoted it to them, like you have to do research that a physician might kind of poke at you a little bit and ask you, what the relevance is. So I'm trying to make it real for them, not just something hokey.
We want them grilled by distinguished
Exactly,
experts.
exactly.
And I don't get no more distinguished experts.
So they're each doing a poster?
Yes, yep.
Very
Yeah, so
nice.
there is something trauma related, and there will be a couple of similar topics, but 18 poster board presentations.
Oh,
So,
great.
yeah.
Can you
Yep.
send an email out?
I can, yes,
Yeah,
as a
yeah,
reminder to
great.
everybody. Yep, of course.
Cool.
Yeah.
What a good experience.
Yeah, I wanted to do something a little bit different. I wanted to do something a little bit different with them this year.
Yep.
So,
So we should also remind folks that EMS week is 15th or 16th through the 21st.
mhm.
And Stop the Bleed Day is May 19th. So So it falls right in the middle of EMS week, and actually we're gonna do MSTAR's gonna do a stop the bleed. Of course, it's fire department, open to providers and to lay people. That'll be that evening. And flow things throughout the week.
You would invite like WMY or WETM to that? I thought that would be a good.
Actually, we're a little slow on the draw. I just buttoned it up with Josh this morning, Josh Baker with the Forces Fire Department. And we're gonna have Karen do a post, but yeah, we'll certainly get it out to that. We tried it last year, but we went up against all call for the county fire departments, so.
I was a brush fire that night.
Yeah,
That's
that's
a huge
right.
fire that night that took
We went right up
basically the
against the
whole
wall.
county away.
So we were a big flop last year.
So on that same note, the organizations through Guthrie are gonna do at Robert Packer Hospital. I'm gonna go with Dr. Lincoln Howell to see about pouring. I'm not sure what we have planned there, but on Tuesday, whatever it is that week, is it the
17.
Yes, Tuesday the 17th, we're doing an ice cream truck along with Air Methods at Robert Packer Hospital. The helicopter will be there. I have a brochure that I'll send out.
Yeah.
We'll have a brochure to send out. So we're doing that, and we have some giveaways and little trinkets and stuff. And then on Friday, we're actually having a couple food trucks available as well. We'll be handing out tickets for a free meal that day. So if any of your folks get down to Robert Packer, Troy, and then we'll work with Dr. Lincoln Howell for them as well. So
Yeah, I think ours will be the Monday, the 16th from 11 to 1. And then there's the hospital here is also doing something else, I believe, on Thursday. So we just have to get that confirmed.
very nice.
Food's a very important topic, so I'm glad that was the last thing on our agenda. I like it. I think our next
Robert?
meeting, yep,
I'd just like to make one other comment since we
Go for
talked
it.
about COVID a little bit. For any healthcare workers, doctors that are employed by the hospitals who have acquired COVID, if you think you got it through your work and patient services, you should have that documented by your employee health services if you're employed because of post-COVID syndrome. Should you lose work later on, you really want to make sure that's documented so that if you have a problem and need to be reimbursed for whatever reason, that there's a paper trail. That's my last comment for today. And aside from making a motion to close the session.
you know I would never let anyone else make that motion, and I will second that motion.
Very good.
My dad, I was just saying, if you find me dead, drag my body.
All right, the next meeting is September 7th, I believe, Mike.
That's
A lot of duty,
That's very line to be dead, right?
Mike confirming September 7th is the next one.
Yes.
Okay. So if that's the case, we've got a motion, we've got a second. I think everyone's in favor and we can close out the meeting this time. Thank you very much, everyone.
Thanks, Rob.
I'm sorry.
Do you have the email the fall ENT class?
Yeah, I get that too.
Okay, my son is on the